a definition which has a broad common sense. To define the resting motor threshold, you need 5 out of 10 or 3 out of 6 TMNs pulses which evoke a reaction. Then you have the definition of the motor threshold, but the system, the software itself, will make the work way easier for you, so you don't have to bother with this. So there is a standardized way to define the motor threshold within the software, and we will have plenty of time playing with it and getting a deep knowledge and how to use it. Okay, here again it's a 5 out of 10. The EMG we can, because you don't have this option, so we can forget about this. And here, as I said, the magnetic stimulator output, the MSO, this means 100%. And the resting motor threshold, the MSO, defines then the individual level where you can see a reaction. And with this level, you will do also the treatment, the stimulation later then. Yeah? So it's very important to have this as precise as possible, because this will have a massive impact on the success of the treatment. Yeah.
Can I write in this?
Yeah, sure.
Okay, thank you. No, I was just talking.
Okay. This is also, we will get in this repetitively, and we will do it practically, so don't bother that maybe now it's not so clear everything, so we will make it clear. Okay. So we have now, for example, we have now tried at my head, and the result is now 40%. At 40% of the magnetic stimulator output, of the maximum output of this machine, there is a reaction, so a visible reaction. So this is my level of intensity under which the treatment then would take place. And then you have certain threshold protocols, we will come to this later, defining, okay, 80%, 120%. So this is all results of international research and a common standard right now. Could be of change, but I think it's very solid. So 5-10 years ago it was still a lot of try and error, but now it's solid. Okay. We are now really in a situation where we have widely approved and accepted routines. All right, so if we imagine, okay, this is the motor hotspot, where we have this reaction, then the therapy is obviously not there. The point where the TMS therapy actually, the coil is placed, is somewhere else, roughly. There is a very elegant way to get to this point. We will show you on the practical side, but roughly for your information, 5 centimeters from there to the front. Yeah. There, somewhere there, is the therapy hotspot. Right. And there you start the treatment. Wir haben ja nicht, wir haben keine Halterung. Ja. Mal schauen. That's okay. Yeah. And as you see, this place has a it's the dorolateral prefrontal cortex. This is the medical name of this treatment point. And it is, again, as I said, very effective for depression. It is very effective for neuropathologic pain, for chronic pain. And there is a different point which has quite how should I say, quite promising results for the tinnitus. Right. And later I will give you an overview about also other things, because when you have these studies, they are often not with a large number of participants. And then you have, in one study, you have really promising results, and in other not so. So
Yes.
and when you have then a meta-analysis, it's kind of not so clear. But you could advise your doctors for certain their diseases or problems, they should at least try it, because there is a significant possibility that with individuals, that you have an individual where this treatment results in the long-lasting positive result. I will get to this later.
In your experience, sorry,
Yeah.
is this machine suitable for epileptic patients as well, do you know?
Well, the epileptic, the thing, if we talk about possibility negative outcomes, there is one thing. If you have a high dose, so you're running with a high level, there is a certain possibility that you create an epileptical episode.
Right.
But we have now, I think every year there are maybe around the world couple of 10,000s of persons treated with this system.
Right.
And over the last years there were, I think, 2 reported cases where such an epileptical episode was created. So it is possible, but the possibility is really, really slim.
I see.
And you have always to okay, what is the benefit, what is the risk? We will get later to this. The risk is that after the treatment, maybe 30%, something like this, of the patients have, for a short term, a little headache. Okay?
Right.
Short term headache, like for 15-20 minutes, but then it disappears.
Right.
If you have a treatment for depression, you normally it takes 4 to 6 weeks of stimulation, and after that you have the same outcome in terms of success as you have with antidepressiva, with medication.
Yes.
The problem of the medication, the side effects are quite enormous. You gain weight, you lose some, you have maybe a bad temper and so forth. So there are heavy side effects. With us, little headache possible,
Right.
but only for a short period after the treatment. And when the treatment is successful, this patient, after 6 weeks, it's set and done. Yeah? Maybe 6 months, 8 months later, a short-term Nachfolge, a short-term follow-up session, yeah?
Right.
Just to stay stable. But this is really, I find this amazing that you have a real alternative to the pharmaceutical drugs.
Yes.
Yeah. So.
To come back to the epileptical, if you have if you have a person with a who is epileptic person, then you should not use the TMS.
Yeah, that's right.
Because they have a higher risk to get an epileptic episode. So if you know the person is an epileptician, then you should not use this.
Right.
This is very important.
It's very important.
Yeah.
Very important.
Yeah. But sometimes you have persons who had, in Germany it's called adolescence epileptic. They only had epileptic episodes when they are kids, childs.
Right.
So then you can, then the physician can decide how, if it's possible. Now how